All right, everybody. Thank you for coming to our first bioengineering series for the spring semester. Last week, I got it all. That figure from last week's been scheduled to communication about that. But today, our first speaker is Dr. Pantalos, and from you.
Thanks for the introduction. And it's nice to be here. Some of you, the rest of you, by the end of the hour, I hope. I intend for this to be an informal presentation. If some of you have been in my lecture in 491, it will seem similar, but it's different enough to see some here as well. And I'm going to ramble a little bit, but eventually it does all come together. And I believe there's only one equation in the equation. So for lunchtime, it's not too heavy duty. Now, just by way of practical introduction, I started out as a rocket nerd, and I assumed I was going to get my PhD in aerospace engineering, and that was going to be my ticket to the first rocket to Mars, long before Elon Musk and Starship. However, I had some interesting experiences that turned me to using engineering concepts and techniques and skills in medical applications. So I then became a cardiovascular surgery research nerd as well. And that also created opportunities for me to work with patients who had medical devices. This happens to be Bob Tools, the first patient in the world to get a totally implantable artificial heart system at Jewish Hospital downtown back in 2001. And then eventually I figured out a way to combine all my interests, and I've been doing a lot of flight research with NASA, medically related, and I'll touch on some of that in the project. And there's even one character sitting in the back of the room trying to look away who's been involved in that work as well. So now, I do enjoy being active in this room that can attest that I do approximate something that looks like playing basketball. It's over in the sack, and previously when what was here was the old gymnasium. And I also did a lot of running. I have not given up either, but as you know, when you're physically active, any mechanical device sometimes wears out and breaks. That includes knees. And so a year or two ago, if you would have taken an x-ray of my knee, this is what they look like. My right knee got reconstructed in 2006, and my left knee has a hemi, half a replacement. I got that in 2013. Well, the reconstruction of my left knee was supposed to last 10 years. It turns out it lasted almost 18 years. So now, if you take an x-ray of my knees, this is what they look like. I have a total replacement in my right knee, and still the half replacement in my left knee is doing just fine. And I am back to riding my bike. I've done a lot of shooting around, haven't actually run up and down the basketball yet, but I think that might happen in the future. And I've pretty much given up running because that was the primary reason why I now have two bionic. Anyhow, thank goodness for biomedical engineers who know how to come up with medical devices like these to help restore people to health and function. Now, it turns out all my teams happen to wear red. In fact, one of my friends teased me I had the logo that day. I did all my academic training up at Ohio A&M. They wore scarlet and gray. And then I was on the faculty at the University of Utah in Salt Lake City for 17 years. They were crimson and white. UL for over 24 years. So, of course, I can also wear red and black. But the other team in red that I am very active in is the Red Cross. Cross. I've been a volunteer for decades. I've been a blood donor since I was in graduate school. And I'm currently on the board. So of course, this is my opportunity to invite you, if you've never been a blood donor, to consider becoming a blood donor. Red Cross does host blood drives here on main campus. We also have one at the Cardiovascular Innovation Institute Sciences campus coming up March 5th. So if you're interested, you can either contact me or you can write to redcrossblood.org, put in U of L HSC and find the blood drive for March 5th and go ahead and register to donate. Now, most of my career I've been involved with cardiovascular devices, but various situations have come up that I've also been able to get in other kinds of surgical devices and a few other things that were unexpected as well. I'll go through some of this during our visit today. And if you have a question, don't hesitate to ask. So the most important thing when you're is to have, quote unquote, the end user and recipient. End user is usually the clinician that implements the use of the device with the patient, and of course, the patient is the recipient. And the goal is for the device to restore their function that has been absent for injury or disease, and to help restore their quality. And what you can see here are several of the different patients that I've had a chance to work with. Tom had a totally implantable artificial heart. There's Bob Tools, who you met earlier, visiting with the mayor at the time. Reed was a businessman who had 2 ventricular assist devices. Reed had, as in that picture, he did so well on the device. He went back to teaching business, and he also opened up 2 pizza parlors while he had his VAD. And then Mike was a high school student at the time. He went on, eventually got a transplant, doing well. Miriam developed end-stage heart disease and wanted to consider getting a device so that she could get well enough to take her grandkids to Disneyland. And as you can see, that did happen. So it's pretty amazing what as medical devices can do to restore health to patients. I can assure you, nobody does this by themselves. It's usually a team or a combination of teams with more complex devices. And it always takes longer than you would expect, and it always takes more money than you would expect. And of course, the fact of life is that they're also regulated by the FDA. So you've got to learn how to get past that hurdle. Louisville has a bit of a history related to medical devices. And in this slide, you can see where I was at the University of Utah on the upper left. That's when they implanted the first total artificial heart as a permanent device back in 1982. And then 19 years later, as I mentioned, at Jewish Hospital, Dr. Gray, Dr. Dowling, Dr. Etosh implanted this first AviaCore total artificial heart system in Bob Tools. And then 20 years later, also at Jewish Hospital, Dr. Slaughter implanted a new integrated cardiac prosthesis or replacement device at Jewish Hospital. And there's even more devices than this, but the point is it's ongoing, but the fact that there was so much time between each generation of devices is an indication of how much effort, time-wise and otherwise, it takes for the more complex devices. As I tease people, if medical devices is not the field that you want to go into with gratification. You got to have a long-term picture, and you get your satisfaction out of the incremental little steps that it takes to develop, test, validate to patients. This was another interesting story. Back in 2012, Oksana Masters was a young girl trained with very substantial defects of both of her legs. She was adopted by a woman, Louisville, and unfortunately excellent prosthetic and rotation capabilities that we have here in Louisville. She was able to get her legs deformed to the point where she could make use of some, at that time, leg prosthetics. And she competed in the Paralympics in several rowing sports at that time. This was back in 2012. She is still competing and has expanded to both in the summer and in the so it's amazing what a lot of will and a lot of hard work practice as well as good medical devices can achieve. Now, medical devices have been around a long time. Shakespeare's attention. Obviously, the goal of an engineer is to make sure that the desperate plans thieves the desperate. Not at all, but sometimes it takes a while to get to that level of function. Now, just as one historical example, here's a well-known healer about 2,000 years ago. As you can see, there are no medical devices in the picture. Right? Take them out. Okay, so the first thing is the bed the patient's in. Hospital beds are regulated medical devices. And there's one fellow that's got 2 crutches and a third person that's got 1 crutch. Crutches are orthopedic medical devices. And of course, this particular healer also had other ways of using healing. So people thought about medical devices for a long time. In fact, even predating this in ancient Egypt, Samuel, you may know this, that what was the original intrauterine device in ancient Egypt? Okay, sorry to put you on the spot, but I thought maybe you knew a little bit of Egyptian folklore, being Egyptian. Now, believe it or not, a rock placed in the uterus of a camel was an effective intrauterine device so that the owners of the camels, caravans, didn't have to worry about their camels getting pregnant partway through the long journey across. Fortunately, intrauterine devices are more sophisticated. But it just goes to show you what imagination and creativity and trial and error can accomplish with a medical device. And about 100 years ago, Eindhoven, who was a physician and a researcher in the Netherlands, demonstrated the first electrocardiograph. And you can see there's wires going from each of his limbs. He's got them in vats of electrolyte solution, probably a salt solution. And then he's got the electronics that can pick up the signal, amplify it, and then create a little squiggle on the smoke chimograph, which is a precursor to a chart recorder or a plotting device that we know today to actually create electrocardiograph traces. And then once you can do that, then you can figure out how the electrocardiograph changes with changes in heart function or heart diagnostic tool for any cardiac patient. But this is how it started. Now, the reality is, at the end, I sometimes ask a question that says, when in the device development process do you need to figure out what regulatory pathway applies to your device? Anybody know? Yeah, early. In fact, thinking to the good old days where you would sketch something out on a napkin when you to you so you forget whether it's a happy hour. So my answer to that question is, you need to start thinking about the regulatory process before that dries on the napkin sketch. Because if you don't, every step of the way has regulatory implications, and how you're going to get your design, how you're going to document your design, how you're going to test your design, everything that goes into that, then how do you results clearly indicate what is the claim you're going to make to the FDA when you submit your application to the device. So there are multiple pathways. I will not get into regulations of medical devices because that's probably several seminars all wrapped in one. Now, the other thing is how does one get involved with medical devices? And sometimes it's dumb luck, and sometimes it's you're interested and you know somebody else who's interested in it. And sometimes you are just so darn creative and motivated idea, start plowing ahead with it. Actually find other people that are interested in helping you, guidance from people. This is, for what it's worth, this is my story. When I was a sophomore in high school, like I said, I was on a fast track to getting my PhD in aerospace engineering, so I'd be on the first. My classmates, however, were in Mr. Webster. Mr. Webster's the guy on the left. See there on the table is an operating. And my classmates in the honors biology class, the way Mr. Webster taught honors biology is you got the full curriculum in biology, and you had to choose a project on a topic, biology, study it in depth, do a project. So this was the fall of 1967. Clinical kidney transplants had just started a couple of years. Clinical heart transplants expected at any time. And so my classmates friends decided to study organ transplantation. And their project was attempting to do a heart transplant on a bullfrog. They did the first one. Oh, I should mention, one of my other skills or talents is I do a lot of photography. So I was this photographer for the school yearbook and newspaper. And the reason why that's relevant, did the first transplant attempt. They learned a lot, heard the pun, but the frog croaked. But they were so encouraged, they wanted to do another one. And as they were getting ready for the next one, they looked at what did we do right, what did we do next time, which is hopefully the iterative process you want to go through any kind of project to advance. And the one thing they noted was they had done a very poor job of documenting what they had done. And all they had to show for it were two very bad black and white photos. If you looked at it, you really couldn't tell what's going on. So they said, when we do the next one, maybe talk George into taking pictures for us. So fortunately, I had a study hall that period. Sounded like an interesting topic. So I went into class to learn what they were doing. And in the process of listening to their challenges, it became very clear to me that most of the challenges are engineering solutions. And that's what got me turned on to the idea of applying things, skills, concepts, design techniques, fabrication, all that stuff, engineering in medical settings. So here's slipping off. So I got an aluminum sheet, got my favorite fastener bolt, Velcro, and figured out a way to, using straps around each leg, to Velcro the operating table so that they would not slip away. One of the other devices was they were attempting to do what's called microvascular surgery, meaning connecting two blood vessels that are 5 millimeters or less in diameter. And in the 60s, that was just an emerging field. One of the pioneers in that, Bob Ackman, was here at the University of Department of Surgery for several decades, and I got to learn from him. But my solution was make an intraluminal insert, meaning make a little sleeve that could act as a conduit that you could slip the end of the donor aorta and the end of the recipient aorta, tie it down with some suture. And then that way, it would be much easier to connect those small blood vessels together. Sure, I created is right up here. I've got lots of the things I'm showing you. And of course, I knew nothing about clean rooms. I knew nothing about good manufacturing practices. So of course, I made this on my workbench using a very finely polished and clean nail as mold, and of course got the finest bathroom caulk on my mom's thread, so I could both longitudinally and circumferentially reuse it. And you know, it was bad, but creating a medical device at that time until I did it later. But the point is, you never know when you're going to be stimulated by a thought or hear about a problem that a clinician is having to get an idea for a new kind of medical device or devices. Now, I mentioned, you've seen this slide before. This is me in graduate school doing surgery where I'm implanting pressure and flow sensors and sampling catheters in and around part of one of my animals that later closed the chest. They recovered, trot back to their cage, and then a week later bring them to the lab and hook up everything and get pressure and flow measurements for my dissertation research. But the problem is, I am not a very strong person, especially in my. And when it came time to close the chest, what you did is you put heavy sutures between the two intercostal spaces of the ribs. And then you got 4 or 5 of them, and you try to pull them together, tighten down the whole ribs together before you start closing the muscle layer and the subcutaneous tissue and final. So what I did just to solve my own problem was I came up with this device here. This is what I'm calling a ribbon. And what you do, 2 hooks goes around 2 ribs that you wanted to bring together, and then you could just crank, and it would bring them together. So my hands, I could then tie a knot in the 5 sutures so that the chest was not going to come undone, and the animal successful. So sometimes you create these devices to solve challenges your research, and other times they're devices that may have clinical benefit patients and physicians. Now, I've also done a fair amount of work in pediatrics, and pediatrics is very challenging. There are a lot of different medical devices are used in pediatrics, rather everything from helping to correct spinal defects that are very debilitating to a patient that as they're developing as a fetus, their heart maybe doesn't have all the chambers, the blood vessels aren't connected in the right place or something like that. So devices can be used for that. The challenge with pediatrics is that the patients are small, devices are even smaller, and the market is bad. So for people who are interested in support medical device development, especially if they come from a business perspective, they want to make sure they're going to make some money out of it. Pediatric devices is not the place most people look. So consequently, both the FDA and the NIH over the last 2 decades have sponsored programs to provide funding to help medical device development on devices specific. And there have been some variations in the way the FDA regulates devices. The one is, well, the key thing is there's something called humanitarian device use exemption, meaning that when you're going to work on your device, part of the process, even before you apply to the FDA to get approval to conduct the clinical trial or start to market it, is you get this designation. And what the designation does is it lets you sell up to 8,000 devices a year, or well, let me clarify that, help up to 8,000 patients a year with your device with humanitarian device exemption criteria. rather than market approval criteria. Pre-market approval means you have to demonstrate the device is safe and it's effective. And of course, that requires a lot of to convince the FDA that. For a humanitarian device exemption, you have to prove the device is safe and it's probably a big difference. At least they tried to make access to medical devices for pediatric patients. Keeping them safe. I've been involved with a small medical device company to afford a pump oxygenator system to provide extracorporeal oxygenation. So for pediatric patients whose lungs didn't develop fully, had a meconium aspiration. What this device can do, it can take blood from, say, the right atrium, put a catheter down jugular vein into the right atrium and draw the oxygenated blood away, put it through the oxygenator, bring it back down to the carotid artery. And in so doing, they bypass the lungs that aren't functioning well for gas exchange. But the device is still providing freshly oxygenated to support metabolism in the rest of the body. And if you look up here at this picture, you can see the dark deoxygenated blood coming in the outlet. It goes through this fiber bundle where oxygen gets transported into it and CO2 gets transported out of it. And the bright red oxygenated blood comes out to go back to the patient. This is a version gas exchange capability. So transport the pediatric patients and also at least partial, if not total. It's still in development, preclinical, starting to show. Hopefully, if things continue to go well, 5 years, it will actually be available as a device for market. I did mention that work. I won't bring up the cardiovascular studies that I did. It'll be interesting. Working in weightlessness is a challenge. But back 2010 or 11, the way NASA decided to organize their thought processes on what technologies did they need for exploration space flight 10 years from now, 20 years from now. There was a whole section on human. And if you went through that, you actually found there was almost a page that talked about having surgical capabilities as part of the advanced healthcare unit. Talking about not being in low Earth like astronauts are currently on the space station. We're talking about crews that go to the moon, set up a base there, spend 6 months or more at a time before they go back to Earth. Even if you're in orbit, you can probably get back to a definitive healthcare hospital depending on where you are within 6 to 24 hours, which is not bad given the situations. But if you're on the moon, you're probably 5 to 7 days away. Significant traumatic injury or even appendicitis. Because if appendicitis doesn't resolve with antibiotic treatment, patient, the astronaut who has appendicitis can get septic and eventually they. Is it anybody had their appendix taken out? Yeah. Okay. So how recently was that? Okay. So they probably did minimum. So what we're trying to figure out is in the environment of a spacecraft, do you want to do a minimum appendectomy? Has its advantages recovery of the patient is faster and minimize the amount of downtime of the member so they can be back and be compared to an open procedure where there's that big scar right down right abdomen. Difference being, of course, this is more traumatic, a bit longer time for the astronaut to recover. However, do a laparoscopic apnea. It takes a heck of a lot of instruments than it does to do procedure. And when you're doing anything for spaceflight, the ideal medical device for spaceflight, small, has no mass, requires no electricity, intuitively obvious to anybody how it works, and so you need to know. There is no such device. Well, that's true, but that's the goal. So trying to come up with what it takes to do invasive apnea on the surface is going to require a lot more. Their open procedure might be a little bit more stressful for the astronaut, but it might be more. So those are kind of trade-offs. You have to think about medical situations in any kind of austere environment, whether it's on the moon, whether it's area on the planet, where it's. Now, one of the things, whether we're working in zero G or Martian G, there's still reduced gravity, and things happen a little zero G. Now, all of a sudden, if it's venous bleeding, surface tension dominates the global blood movement. So hopefully you can find where it is, stop the bleeding completely away. On the other hand, if it's arterial blood, which has a lot of pressure, it happens on Earth, squirts up, and then it comes right back down on the operating table. If you do it in zero G, it squirts and it keeps going until it maybe a spacecraft, and then if it still has enough energy, it bounces and it goes someplace else. And it keeps doing that until it runs out of enough energy that surface tension. So that's the situation that you don't want to contaminate the spacecraft, and also to prevent something floating by and contaminating your surgical field. So we worked on two different types of containment dome. This one's rigid and it's got 4 microscopic probes. And then this one, it's a little bit smaller. It's very flexible, just like the other one. This is skin. But there's a holder which is 3D printed, so it's much more flexible. And it has this barrier diaphragm, which is a medical grade polymer that has the unique feature that it self-seals. So get this onto the skin. It's very low profile, so you can insert the instruments just like you do. And then when you pull it out, because this is self-sealing, it seals off the hole. So the insufflation pressure that you have to access and get the patient where you go is maintained. So you have to think of multiple options as of the circumstance that you present. And we've done fresh cadaver procedures where we've tested out. This is work that doing in collaboration with surgical unit out of Travis Air Force Base in California. And so here you can see the low profile one, and the surgeons that were using it, they said there's virtually no difference with this and what we normally do. And that's good because you don't want to give surgeons something So that, we're thinking that for this project, we're probably going to go with this device, which is smaller, easy to make. In fact, some of my students are to our next project next. And we've even tried applying the dome in zero-G airplane that these two students are now, Morgan was a med student, Trey was a biology student. Morgan's now an attending surgeon down at Banner Hospital in Phoenix. Trey is finishing up his anesthesia residency at Cleveland Clinic and may be coming back to Louisville for his cardiac anesthesia fellowship. But here he said they're starting to put it on, and then they're finishing putting it on. Morgan's making sure it's very nicely stuck, and things you can do in zero-G that you can't do in 1G is lay or float horizontally over the patient to check something out. And then another thing is to minimize what you take, but when you're going to do some surgical lead time. So it would be smart to have a small that are sterile. So if it isn't, but if it's not, and if it's going to be 3D print for instruments. Now, there is an initiative at NASA called Fab Lab, started back in 2017, although 3D demonstrated several years ago. And in fact, it demonstrated printing plastic, tissue, and last year they demonstrated being able to metal in microgravity. So it is stuff, so you don't take all of it. So here are examples, and I have these here too, up here for you to check out, where this is a clinical hemostat, and these are 3 different versions. In fact, this one here, it was printed, the 2 halves were integrally printed, so that you're printing the left half and the right half connected here by this center hub all at the same time. And then all you had to do was, when you take it, just open up the pieces so that they could then rotate the way you normally need to hold it as hemostats. This is a clinical number 3 scalpel handle, and this is a 3D printed number 3 scalpel handle. And this is an enlarged handle, number 3 scalpel handle. The reason why we made the enlarged one is that it's also reasonable exploration spacecraft or surface station. Not only to expect there to be the capability to 3D print things, but there will probably require a dexterous robot to act as an assistant. And so another project that where they have a robot named Robonaut 2, kind of looks like a beefy lineman. Not quite as good as that. So Robonaut 2 could identify, but had a hard time. He couldn't consistently pick up this size, standard size scalpel handle, but he could pick up the enlarged one, which was just an adjustment. Now, the other thing is this device, which is volumized bigger, has less than 1/6 the mass of the standard clinical one that's made out of stainless steel. So there's also the mass savings devices. And of course, these are forceps. And we have tried these out in some of the animal surgeries at the Cardiovascular Institute. You can see using the scalpel handle to do a skin incision for a lung procedure, doing a puncture of the pulmonary artery to put in a cannula, and then using the hemostats to hold some draping material in place. Now, in spaceflight and surgical procedures, instrument exchanges take time, and there's always a chance of the other thing is there, which is just bad, the surgeon may make it distracting, not be able to get their eyes on the surgery. So to try to minimize that, several of us, including Dr. T, who's sitting there in the back, created the thing with surgical magic wand. And looks like a slightly enlarged surgical wand, but with the buttons, suction, irrigation, vision, and demonstrated this zero-G airplane flights where we're testing it out and other surgical techniques. And it also flew on our suborbital space flight a few years ago. So here you can see on a zero-G flight, we do these inside a glove box just in case the squirts get out of control. But we have a bleeding wound model, and then here you can see I've got the multifunction device with the shaft down in the wound, and I'm pressing the button so that I'll get suction to clear it out. And then here you can see a large version. It looks sufficiently realistic that people who don't do medical work, a couple of them have gotten queasy. So it's a fairly high fidelity simulation of the situation that you would encounter in zero-G. With any medical device development, there's several key steps early on. What's the unmet clinical need? Customer discovery. What does the person who's going to need it, what do they want? What are they looking for? One of the current buzz phrases is what's their pain? What irritates them? And what either modification of an existing device or what new device could alleviate that pain for them? And then what's the market size? Chance to actually experiments with. What's going to be the experiment? Never done all over. Don't proceed. To another device. Well, this is an example. Is that currently available commercial trocars, pantalos, which are the devices that you stick inside, like inside the abdomen, appendectomy, sticking in surgery. They leak. If it's an appendectomy, they arthroscopic. On Earth, that's tolerated. It's wasteful, but it's tolerated. But you can't have that in a fairly small enclosed spacecraft. So what we did is several of my students and I, we did a bunch of ones apart. And then we figured out, okay, given that, what's the source? And now, top where the instruments introduced. So what we did is we redesigned the diaphragm seal, and then we added 2 valves that are critically spaced so that when you're introducing an instrument or withdrawing it, there's a pressure seal so that the pressure down here in the abdomen or in the joint is maintained and stuff doesn't leak. And then this is a family of 5 different trocars that have been created for different types of surgical instruments and surgical procedures. And I've got 4. And we have used them. And there'll be a picture here in a little bit. Part of customer discovery, I talked to surgeons that use the devices to find out what their beef was. I talked to well, different kind of surgeons. And then I also talked to the surgical supply manager at Jewish Hospital because they have a complete perspective. But all those perspectives are helpful in your device development. And then as far as the trocar market, at least this was a few years ago, you know, it's a couple $2 billion market. So even if you can just start out with a small fraction of it, you're still making money to keep the project going. But then hopefully in time, maybe it can expand somewhere into this region. if you're successful. And then as far as killer experiments, one of which was doing fresh cadaver studies. And here you can see with 2 of the 4 trocars, we were simulating doing and both the surgeon and the surgical tech who were in 2 of these, they were just amazed how dramatically different experience surgeries don't have the leaking solution coming out. And dealing with a mess costs a lot of money to surgical supplies. So there have been some medical device companies that have shown interest, yet, but maybe someday they will. And so I mentioned we had a suborbital flight with Virgin years ago. You may recognize this character who's sitting with us in the back of the room, Dr. T. Sienna is currently a PhD student. Clara did her undergraduate here. She's now doing her PhD in California. But this is pre-flight in the hangar. And then this is a picture actually of the unit in flight. And you can see here's one of the containment domes. Here's one of the leak-free trocars. And here's one of the multi-function devices. And we tested all of that. Well, Spaceship Two was floating through space for a period of about 3 minutes before it came back. And then here we are celebrating by Spaceship Two once it came back with our successful experiment. So it's a pretty amazing experience. Now, what was also an amazing experience, one that wasn't, one can't. Somehow or other, I got it's probably from the project. And they said, biggest problem getting enough sampling test kits was getting enough back of the fence. And so there was this, that, and the other, and some people said that's interesting. I don't want you sticking that. We thought we could come up with a design in a way that could at least temporarily provide blobs until the manufacturers could their production and increase their market distribution. So what you can see here is about design iteration number 5, where there's a rounded tip on the swab. There's a open lattice here to capture samples of the mucus from the back of the pharynx. And then the rest of it was a handle that had a little break point at it. Several of them are not these. But you can see the if you want. And we did, there's putting the viral transport media in a 15 ml tube. We created both the package for delivery and return from a biohazard bag with the instructions for use on the bag. And by the time we were done, here you can see Sienna and Clara again, and then Joellen, a mechanical engineering student, celebrating we'd made our 10,000th kit. To support Bell and research related to COVID-19. So when we started working on this project, somebody said, what do you know about infectious disease? Don't get microorganisms, I know the avid here, but I did know something about medical device experience. And a short period it was about 6 weeks. Started on this. That was after clinical trial that lasted 3 weeks. So we did head-to-head comparison of a commercial swab. Efficacy, good sample. Now, let's see, we're getting close to running out of time, so skip by this one. Just a few other suggestions. You're going to have all of these questions when you're going through your validation procedures, but the one thing that I can't emphasize enough is that it's important that you document what you're doing. Because the FDA will tell you, they get your attention, but it's true. They'll say, if you didn't document it, you didn't do it. You can't show them the data. It's gonna that your device documentation is what the hospital, and it's whether it's documentation is some kind of measurement that you make that critical with it. It's the other key thing. How do we document that? Because processes often take a submission to get approval. But if you have it well documented, you're still going to get questions from the FDA when they first review it. But questions, it's data that you need. Don't do that. When you haven't documented times where it answers questions from the FDA, it takes a lot of time, takes a lot of effort, especially startup. That's why documentation is extremely. Now, a couple of things to be aware of is to do a risk analysis of your device, interior safety side of it. And basically for risk, it's the probability or what's the likelihood of something hazardous happening with your device times the severity or how much of a hazard does it pose. And there are in fact severity ratings anywhere from negligible up to catastrophic. Tend toward negligible if you can. And then of course the likelihood or the probability is every time, which of course is what you don't want, down to improbable, meaning maybe once in the entire lifetime of the products. So risk analysis is important. The other thing is, especially for a device, is reliability. And many people use reliability as well. It's 95%. Submit to the FDA that doesn't tell us how reliable it is. Because what you need to tell them is a technique called Bible statistics to determine percentage reliability. A stated mission line is to go for 2 months, years. But confidence, so you have to report those 3 things when you're talking about the claim of reliability document. It's not just a single percentage. And of course, FDA website is a great source of information. And believe it or not, you'll see a tab there that says Ask Us. If you send them an email, generally they answer. So they like to try to be as helpful as they can. And part of it is because it's nice to be helpful, but the other thing, it's in their own interest because they know if they're helpful now and you ask more questions when you're writing their application, they're going to get an application that's well organized, it's understandable, which makes it easier for them to read your application and then get you questions back. If you just do it daily, they've got it. So it's important. And the other thing, this third thing I mentioned at the bottom, is schedule a pre-submission meeting with the, in this case, it's the Center for Devices and Radiological Health. My submissions go with generally the in your submission. And do this when you pretty much got your design finalized, when you've got functional data. But it's before you do your preclinical, meaning your final testing. It's going to be the patient. There's a couple of different ways to do this, but they will give you a lot of good feedback that's going to either bring up other things, pieces of information that they'll be looking for, ways of organizing so that it's going to make it and make the review process be less painful. The other thing is that the FDA's criteria product is safe and effective. As I mentioned, for a humanitarian device exemption product, safe and proper. But CMS, government agency in Health and Human Services that does reimbursements for medical devices, their criteria is reasonable, necessary. So just because you've gotten FDA approval doesn't mean that's very important. So you have to have people that also work on marketing and reimbursement strategies so that when you get to the point when your device is approved, that you can not only market it, but get insurance to pay for the use of the device, or at least enough of the use of the device that the hospital is willing to use the device. And then it's also important to know the different types of codes that make the reimbursement process go better. Because the last thing you want to do is have the FDA show up at your company operating room, time out, you have your device. Communicating with the FDA is very, very important. Because ultimately we want our patients that are the recipient of the medical device to have a good quality. So with that, we got maybe a minute or two for questions, and thanks again. But if you want to come up and check out my business. Okay, well, if you think of them, you can, later, Dr. T knows how to get a hold of me. Hey, good to see you.
Yeah, good to see you. I'm sending an email regarding Is it called like SBO?
It's either an SBIR or some other kind of
Okay.
NIH grant.
Yes.
Yeah, okay. Thanks, Amy. Good to see you.